Welcome back, students, to Part 81 of the Masterclass. Now, in Part 80, we built out your executive financial dashboards and modeled the case mix index. Today, we're taking that analytical foundation and applying it directly to the clinical logic of the chart. We are diving headfirst into the high-acuity, high-revenue world of major diagnostic category 05, diseases and disorders of the circulatory system.
But hey, before we break down the clinical coding rules, I have a really quick favor to ask. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is absolutely crucial because it's exactly what allows us to keep bringing you this advanced masterclass completely free. All right, here's our agenda for today. We've got an overview of MDC05, heart failure DRGs, MI logic, CDI and compliance, and a look ahead to our next lesson. We are connecting abstract rules directly to hospital revenue, so let's get right into it.
Kicking things off with Section 1, MDC05, Clinical Scope and Structural Partitioning.
So MDC05 is an absolute revenue powerhouse, but you have to remember that it's entirely dependent on the principal diagnosis. The condition established after study to be chiefly responsible for occasioning the admission. Once that diagnosis actually lands a case in MDC05, the MSDRG grouper splits it into two buckets, surgical or medical. Significant OR procedures like a KBG or a PTCA, those go straight to surgery. But today's explainer, we're focusing strictly on the medical side. We're talking about treating conditions like heart failure, AMIs, and syncope with medicine and monitoring.
To really master this medical side, you absolutely must control these core elements: principal diagnosis, complications and comorbidities, or CCs, major CCs, and the present on admission, or POA indicator. Accurately capturing these elements is what prevents massive revenue leakage. Seriously, a vague diagnosis simply strips away your CC or MCC status, and that is going to instantly tank your DRG relative weight.
Moving right along to Section 2, high-volume medical cardiovascular DRG families.
Look, vague documentation in these families practically guarantees a lower-paying DRG. Precision is your only real defense here. Just take a look at the DRG triplet for heart failure and shock. DRG 293 is heart failure without CCs or MCCs. That means low severity and low payment. But capture a complication and you jump to 292. Accurately capture a major complication and you land in DRG 291, securing the exact reimbursement needed for a highly complex, resource-intensive patient. So you might be wondering, how do we actually get to that higher severity? Well, you do it by avoiding the term CHF. Simply writing congestive heart failure automatically defaults you to a lower DRG. You need specificity. Is it systolic, meaning HFrEF, or is it diastolic, meaning HFpEF? You must document specifically with terms like acute on chronic systolic heart failure, which is coded as I50.23. The clinical indicators to support this MCC include an ejection fraction of less than 40% systolic, elevated BNP levels, findings of pulmonary edema on an X-ray, and the aggressive use of IV Lasix. Guys, you just have to show the work in the chart. Let's dive into Section 3, acute myocardial infarction and coronary artery disease. Let's look at those acute MI rules. First things first, you've got to capture the anatomy. Is it a STEMI or an NSTEMI? Then, you must differentiate the underlying cause. Type 1 is a spontaneous MI due to a primary coronary event, kind of like a plaque rupture. Type 2, on the other hand, is secondary to a supply-demand mismatch, usually caused by severe anemia or hypotension. And watch out because payer auditors actively target Type 2 MIs for downgrades if the underlying demand ischemia isn't explicitly linked by the physician.
And let me tell you, the coding rules for MI are strict. If a patient is admitted for an MI, it's considered initial. But if they're readmitted within a 4-week window with a new site of MI, it's coded as a subsequent MI. Also, remember the inpatient rule for qualified diagnosis. If a patient presents with severe chest pain and the physician documents rule out myocardial infarction and treats the patient as if they actually have an MI, it is coded as the principal diagnosis for that inpatient stay right alongside the associated symptoms. That rule-out guideline is an absolutely crucial distinction.
Now, chapter-specific guidelines. Man, these are a massive trap. You can't just code essential hypertension if the patient has heart failure. The guidelines require you to link them using the combination code I11.0 or hypertensive chronic kidney disease using I12. Failing to use these combination codes means you're failing to capture the true clinical severity of your patient.
All right, Section 4, high-yield CDI, clinical validation, and audit compliance. Welcome to what I like to call the revenue rescue phase. You've got to capture secondary conditions that are running parallel to the cardiovascular event. Always look for acute kidney injury, specifically cardiorenal syndrome type 1. Watch for severe sepsis, acute respiratory failure, and severe dysrhythmias like rapid atrial fibrillation or ventricular tachycardia that require continuous telemetry and antiarrhythmic adjustments. Also, if an MI patient is intubated, failing to document the exact mechanical ventilation hours will literally cost you dearly. Let's look at a real-world scenario. A patient is admitted with heart failure and acute kidney failure. Now that's an MCC, but the present on admission or POA flag was missing. Because of that, the grouper immediately treats it as a hospital-acquired condition. It negates the MCC weight entirely and drops the whole case to a low-paying DRG 293. In this case, a concurrent CDI query was the only thing that rescued it, confirmed the kidney failure was present on admission, and restored that MCC status.
Now, obviously, you can't just ask a doctor to code for more money. That is compliance suicide. Per AHEMA and ACDIS guidelines, queries must be non-leading. You provide the clinical indicators found in the chart, like the elevated creatinine and the IV hydration, and then ask the physician to clarify the diagnosis. For example, you'd say, based on the EF of 35% and IV Lasix, please clarify the type of heart failure, acute systolic, chronic, acute on chronic, or other. Give them the choices and let their clinical judgment decide. So, what does this all mean? Let's talk dollars and cents. The payment formula is the hospital base rate multiplied by the DRG relative weight. If your base rate is $6,000 and a compliant query moves a vague heart failure case to DRG 291 with an MCC, which, by the way, has a relative weight of 1.3, your reimbursement is $7,800. A single, properly queried MCC secures thousands in rightful reimbursement for the exact resources your hospital actually used. It's a game changer. Which brings us to Section 5. Our summary and a quick teaser for Part 82. To quickly recap, precision in MDCO5 is everything. Distinguishing MI types, proving heart failure acuity, and deploying compliant CDI queries for secondary dysfunctions like AKI are for sure your best defenses against audits and revenue leakage.
As we wrap up this pretty intense session, I want to remind you all with immense gratitude. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
We've completely conquered the medical side today, but half of MDC05 still awaits us. In Part 82, we're crossing over into surgical DRG logic, tackling complex ICD-10 PCS root operations for CABGs and pacemakers. Ask yourself, if your facility is losing thousands on medical documentation, how much are you bleeding in the OR? Keep studying, keep querying, and I will see you in the next masterclass to find out.